Hi, my name is Michelle Robin and I'm Professor of Radiology at the University of Alabama at Birmingham. Today I'm going to be talking about the swollen extremity in the hemodialysis patient. First, a disclosure, I'm the director of an ultrasound core lab for an NIH U01 hemodialysis fistula maturation study. I have really no significant conflicts of interest. We're going to talk today about what clinicians are looking for in the swollen extremity, how to triage with ultrasound, a brief slide on billing because it's very important. You need to bill exactly what you do. And then we're going to go over the focal findings that you will see, both common and uncommon, and show examples. So the extremity swelling with access is a very common indication. We see it coming out of the ER with less experienced personnel that are not used to seeing a lot of fistulas and grafts. We see it in the outpatient department and also from the inpatient service. What should happen prior to the request for an ultrasound, and this is optimal but doesn't always happen. First of all, the clinician should do a good clinical physical examination and get a good clinical history. For example, do they have a graft? Do they have a fistula? When was it placed? They should also listen to the graft as well as put their hands on the graft, because often if there is a stenosis present, you can feel the bruit. And then they may or may not have labs that are drawn to assess for dialysis adequacy, because this may be a problem that is brewing for some time. So for the clinical history, again, you need to know whether this is a graft or a fistula. And this is a plea to actually use the correct terminology. A graft is PTFE material. In general, there are some newer graft material, but generally it's PTFE, and it's a connection between the artery and the vein by some synthetic material, either in the upper arm, forearm, or in the thigh. A fistula is a direct connection between the artery and vein, and please use the correct terminology. It confuses the sonographer and sonologist if we see something that doesn't look like what should be there. We also need to get the history of a prior access or a central line. For example, if the patient has had a recent central line and now comes in with arm swelling, our focus is probably going to be more on a DVT or a stenosis than maybe access malfunction. Recent surgery, again, it's important to know if this graft is new, or if the graft or fistula is new or old. And also recent hemodialysis. And I'll show you an example later of a patient that came in with acute arm swelling after hemodialysis. Each of these have different differentials. So first we're going to start with a patient that comes in with a clinical history of pain. And for the painful mass, generally we're thinking about infection. It could just be a hematoma. It doesn't have to be infected, or a pseudoaneurysm. Sometimes they can be painful, sometimes they're not. This is a very gross example of a very large palpable mass. This is 15 centimeters. Obviously, it can cause pain just by its size. The question is then, is this infected? Well, I can't generally tell from these images, but we'll talk about that in a minute. But what do we do when we want to determine if it's a pseudoaneurysm, which is a very big consideration in this huge mass? We put color on. And color will show that this is a graft. You can see the graft material here, and we didn't see any communication with the hematoma around it. The other thing that can cause pain, although in a slightly different region, it's not a focal mass, but pain during dialysis. And sometimes people come in with that history, and then sometimes that pain starts to get worse even off of dialysis. And in those cases, we need to rule out steel. So this is a patient that has arterial steel, and the way that you diagnose that is this is the artery caudal to the fistula anastomosis, and here you can see the flow going up towards the arm, which is the opposite direction that a normal self-respecting artery should be going in. And you notice that it's low resistance flow because it is feeding the artery. What you do to put the icing on the cake is to transiently compress the graft or the fistula, and you'll see reversal of flow and a more normal high resistance waveform, because then that blood flow is only going to the extremity. It's not going to the graft or fistula itself. So don't compress it too long, but it's perfectly okay to do a transient compression to show this kind of image. So now we're going to move on to a patient that doesn't have a focal, or that does have a palpable mass. Again, an abnormal physical exam, not complaining of pain, but a palpable mass. And again, the differential is hematoma, and there may be gas, but remember that they stick these grafts and fistulas with a 17 gauge needle in general, and so there could be gas from that. So just because you see a gas bubble or two doesn't mean it has to be infected, but of course you can't exclude it. This is a patient that has a very large palpable mass, and again I'm basically showing you with reference to this and a few other images the most obvious and egregious examples that I can show you to illustrate it, but be assured that most of the images I see in my day-to-day practice are much smaller than this. But this is a very large palpable mass. And you can see the graft going through it. Well, what would you do to maybe figure out if this is an acute hematoma, or if this is, because if it's an acute hematoma, the debris inside is probably not going to be very malleable. It will be like jelly. But if it's a focal abscess, there'll be a lot of debris and you may be able to compress it. So given the right clinical history, we're worried about abscess, and this is a patient that if you use compression, you can see there's a lot of debris in here. So I'd be very concerned in the right clinical setting that this could be an abscess. But of course it could, I suppose, be a resolving hematoma. You can also see there's a graft adjacent with the tram tracks or the parallel lines. That is what we normally see for a graft. Moving on to a pseudoaneurysm as another etiology for a palpable mass. Here is a typical pseudoaneurysm. This is the yin-yang appearance, a to and fro, and then be sure when you're describing this to not call just this patent part a pseudoaneurysm. The pseudoaneurysm is really the entire mass, whether it's thrombosed or not. Now, if there is no patent portion, then it's just a hematoma. I suppose it could be a thrombosed pseudoaneurysm. But when you have something that is a pseudoaneurysm, be sure to not just describe the dimensions of that pseudoaneurysm as within the patent portion, but describe and measure the entire mass. This is another patient that came in and originally was thought to have a big pseudoaneurysm. You can see there's a lot of blood flow here. It kind of has the appearance of a yin-yang, and there is a lot of low or isoechoic around this graft, and there's a huge hematoma around this. Well, when you look at it a little bit more carefully, there's actually a rent in the artery that is feeding this graft, and here's the rent, and that's just draining into a huge perigraft hematoma. And this is a surgical emergency. If you see this after you've diagnosed it, you should hold pressure, because you can get a compartment syndrome in a hurry, and the patient can bleed quite a bit into an extremity. Other abnormal physical exam findings: sometimes these patients have no thrill. Sometimes we get this from the dialysis lab, where they come in and the patient really didn't notice, but the dialysis nurse says, well, you know what, I don't feel a thrill. But most of the time, those dialysis nurses are quite experienced, and they say, well, that means it's not working well and it's probably thrombosed. But the emergency room departments generally tend not to have quite as much confidence as the dialysis nurses, because they don't see them every day. And so they may send them to us to make sure that there is a thrombosed graft or fistula. And it could be partial, it could be complete. This is something that you can't just sign off the report. You need to call, and because someone may want to do a declot of that graft or fistula sooner than later. Now, if you feel or hear a bruit over a draining vein, that's more typical of a stenosis. And the most common place for a stenosis is in the draining vein. We'll talk about that in a minute. First, I'm going to show you an example of a thrombosed graft. This is a graft that has a lot of low-level echoes in it. We put color on it, and we don't see anything. We could optimize this image even further by decreasing the scale, going from a medium to a low wall filter, and even putting power Doppler on if we really had any question about the fact that this graft is completely thrombosed. This is an example of a draining vein stenosis, and the arrowheads show, again, the typical graft material. Here is the end of the graft, very nicely shown. You can see we can be very, very specific with regards to the location of the end of the graft, in contradistinction to angiography, where they may not know exactly where that graft ends. And then where the asterisk is a stenosis. So here we're getting visual confirmation of a draining vein stenosis. And we'll talk a little bit later about how to diagnose that and how to assess the severity of the stenosis. The physical exam can also be abnormal, not with a focal mass, but with generalized swelling. And when I think of generalized swelling, I generally think of central or proximal draining vein stenosis or occlusion. And occasionally we can see in these patients a DVT, usually of the brachial or of the axillary veins, and those are things that we need to think about. This is an example of a very swollen upper arm, and this graft actually is occluded. We don't have color on, but it is. And you can see all this low or hypoechoic fluid that is just edema that is in the interstices of the subcutaneous tissues. So this is what is a typical pattern seen with generalized swelling. So we need to investigate that further to determine what the cause is. This patient has a DVT. They have a brachial vein thrombus. Remember, the brachial veins are paired, so you may have thrombus in one of the brachial veins. It may be in both, and the way you can tell that they're deep veins, they're paired brachial veins, that they travel with the brachial artery. Another cause for an abnormal physical exam is poor inflow, although that is quite uncommon as a reason to come to ultrasound. You can see a stenosis in the feeding artery or at the arterial anastomotic stenosis. Graft arterial stenosis is fairly uncommon, as is an arterial stenosis in the feeding artery. A juxta-anastomotic stenosis in the fistula is quite common, but it's an unusual cause of arm swelling because it restricts the flow in the arm. I define juxta-anastomotic stenosis as anywhere within 2 centimeters of the fistula anastomosis. So you can have edema distal to the graft. You could have difficulty in cannulation. Another clinical finding of stenosis is prolonged bleeding at the needle sites or pulling clots out of the graft or fistula. And finally, an unexplained decrease in KT over V with a stable dialysis prescription. And that is something that the clinician may have some idea that there is a stenosis. Now, if the clinician is pretty convinced that there's a stenosis, they really shouldn't be sending the patient to ultrasound. They should be sending the patient to angioplasty because that stenosis can then be treated with angioplasty. So this is a diagram of really what we're looking for with that history, because you really don't know when the patient walks in the ultrasound suite if we're going to be looking for, we know we're going to be looking for swelling, but we don't really know if it's going to be focal or diffuse, because usually our clinical histories are good, but not exactly comprehensive. If it is a focal swelling, really we only want to look for that focal area, looking for a mass, and then that mass can either be a hematoma, it could be infected or not, or it could be a pseudoaneurysm. If there's more diffuse swelling distal to the axis, it's not exactly focal, but it's kind of not the entire arm, then you need to ultrasound the entire axis. And when I'm describing this, this is what you should be using for thinking about what you're going to bill and what kind of ultrasound you need to do, because you don't always need to ultrasound the entire axis. If you have diffuse swelling, then you do need to ultrasound the entire axis. And if you still haven't found a reason, then you need to rule out DVT and ultrasound the arm or leg. And the reason why I keep talking about axis and extremity rather than arm or leg is because you can have a thigh graft. We don't typically have fistulas in the thigh, but you can have a thigh graft, and so then you would be looking at the central circulation in those as well. So one slide about billing in 2011, at least as of this date. If you're going to only look at a focal mass, you need to do the soft tissue exam, 76882, and if you're going to do the entire axis, either a graft or a fistula, that's this CPT code 93990, and that's graft/fistula with Doppler of arterial inflow, body of access, and venous outflow. So this is a pretty comprehensive examination. To my knowledge, there is not a limited CPT code for just a limited study. But if you have a graft or a fistula and you have a problem and you're evaluating it, then you need to do this comprehensive study. You should not be looking to bill a unilateral extremity arterial or venous code. But if you then look for a DVT in the upper extremity or in the lower extremity, you need to bill a limited or unilateral CPT code, which is 93971. But you'll need to check with your local people to make sure that these are correct, of course. So again, the focal mass is the majority of the referrals, and usually there is a good focal mass clinical evaluation, so we kind of know what we're looking for. So now we're going to move towards talking about these individual entities that we see. With a pseudoaneurysm, always turn color on, because you never know when you're going to get a pseudoaneurysm. Any hypoechoic collection you see, turn color on. One time I had a routine DVT study, looked like a Baker cyst in the popliteal fossa, and it turned out it wasn't a Baker cyst. It turned out it was a pseudoaneurysm from a gunshot wound. Another time there was a big popliteal artery aneurysm. So you need to always turn color on the hypoechoic collections, particularly when you're looking around a graft or a fistula, which have so much blood in them. Now, the graft wall will commonly degrade to form little pseudoaneurysms, and in general, nothing is done about them until they get to a reasonable size. And that definition of reasonable changes with the patient and with the surgeon. You may also get a pseudoaneurysm from inadequate pressure after removal of the dialysis needle. So this is an example, a grayscale image of a degenerating graft, and here's all these little pseudoaneurysms. It's pretty common with an older graft. And this is color, putting color on, and you can see all these little patent outpoachings from that graft. It is a synthetic material, so it cannot repair itself after repeated sticks. So again, in focal mass evaluation, now we're going to start talking about the individual entities in more detail that can cause a focal mass. For a pseudoaneurysm, remember to optimize your settings for low flow. Of course, if it's a big rip-roaring pseudoaneurysm, then you can turn up your settings as needed. But first of all, optimize your grayscale, and maybe bump up the grayscale gain just a little bit to make sure that there's not some low-level echoes or some hypoechoic thrombus that you're missing. Then turn the color gain up until the pixels are displayed just outside the vein where they shouldn't be, and then turn down until they're just gone. Decrease the color scale, decrease the PRF, and make sure that you have a low wall filter, and just to be sure that the probable hematoma that you're looking at isn't a pseudoaneurysm with low flow. And if you really think that you need it, you could put power Doppler on, but typically it's such a superficial structure that we don't need it. Then you need to assess the depth of the pseudoaneurysm, and that's very important. The other thing that we don't typically do in ultrasound is to turn the light on, and you need to look at the patient's skin. Assess, first of all, you could look with grayscale, put some color gel on, or some gel on, so that you can see where that anterior-most wall, the pseudoaneurysm, is, and where the skin surface is. But then look with the lights on and make sure that that skin surface isn't ulcerated. because these can bleed. The patients can exsanguinate, and that does occur every year in the U.S. I can't tell you how many people actually do bleed out, but I know it occurs. Sometimes I've been so worried that I've gone over with the patient what they should do if they start bleeding. And you're going to want to tell them to, grab their arm, put a tourniquet on if they can, or a belt or something like that, not just hold gentle pressure, but very, very hard pressure, and call 911. Now, you may call the surgeon and they say, oh, that's okay, they can come to clinic in a couple days. If you're that worried about the patient that pseudoaneurysm could rupture, then you need to say, I'm sorry, no, this patient has to go to the ER or they have to come to your surgery clinic today. It's very, very acceptable for you to be that firm, and the patient will thank you for it. And again, you may need to discuss the rupture scenario with the patient. I haven't done that very often, but those times that I've been very concerned, I have. And occasionally we do escort the patient to the emergency room. This is an example of a graft pseudoaneurysm. It is off the distal end of the graft, and it's a big one. And we generally, this is big enough to deal with that day or put them in the hospital at least so they're under observation. This is another odd pseudoaneurysm. It's a patient that we were mapping them for a dialysis access, and they had a brachial pseudoaneurysm. And you can tell that it's old because there's some calcification around the periphery here. This pseudoaneurysm is likely from a prior needle stick or maybe a line. And you can see this is a typical pseudoaneurysm. Again, remember when you're describing the pseudoaneurysm, talk about the entire surface, measure the entire volume of the pseudoaneurysm, not just the patent portion. That's going to be important at surgery. So, would you like to do thrombin injection on these? I don't think so. I think it's, generally there is a wide neck for these pseudoaneurysms. You run a big risk of having the thrombin that you're injecting go back into the circulation, and these are best handled surgically. In the old days, when we used to do compression, I have tried compressing a few of these when they were relatively acute, but most of these have been around for quite a while, and you will generally not be successful with compression. So I would just send them to the surgeon. Now some of these small ones, they don't have to go to surgery right away, they'll just watch them. Now, if you don't have a pseudoaneurysm and you have lots of echoes like that other case that I showed you, you need to worry more about infection, but you really can never know for sure whether something is infected or not unless there's gross air bubbles within. But again, a hematoma is very common. These patients are on hemodialysis 3 times a week for 4 hours at a time, so they've got lots of hematomas. And when you're describing this, be precise as to the location. Say where exactly it is, because if they go to surgery in a day or two, that hematoma may have decreased in size. So you need to be precise. All right, so now if we have swelling, moving on to that, usually the swelling is distal in the extremity, and then you need to look at the entire axis. And when you ultrasound the axis, either a fistula or a graft, you need to look at the feeding artery, at least the lower third, the anastomosis of the artery with the graft or fistula, and if it is a graft, you need to look at the arterial and graft anastomosis, and then the graft and venous anastomosis, or if it's a fistula, just the arterial venous anastomosis. And then you need to look through the entire draining vein. This is an example of a hematoma causing a stenosis. There's so much of a hematoma here, this is up near the axilla, that it's frankly causing compression. And these may get better, but you may have to have evacuation of that hematoma. And you can tell this is a pretty decent stenosis, not only visually, but because the peak systolic velocity is over 4. And I don't usually use that as a gradation. We use it as a peak systolic velocity ratio, but I know that the feeding artery was a lot lower than 4. So how do we evaluate stenosis and what the degree of stenosis is? We look at the peak systolic velocity ratio. And this is a tube. This is all just plumbing. Here's the stenosis at B. The blood flow is coming in from A. Here's the post-stenotic dilatation. And here we obtain a peak systolic velocity at B, take a peak systolic velocity at A, 2 centimeters upstream from the anastomosis, and we use that ratio to determine the degree of stenosis along with a visual assessment. So this is an example of a juxta-anastomotic stenosis in a fistula, 2 centimeters proximal to the anastomosis. The feeding artery peak systolic velocity is 102 centimeters per second. At the stenosis, we have a peak systolic velocity of 861 centimeters per second. So that gives us a peak systolic velocity of ratio of 8 to 1. What ratios do we use? Well, it varies a little bit. For a fistula, if it's a juxta-anastomotic stenosis, we use a peak systolic velocity ratio of greater than 3 to 1 and a visible narrowing. For a graft, at the arterial graft anastomosis, that blood has to turn on a dime and go whipping back up the arm. So sometimes you can get a peak systolic velocity ratio of even greater than 3 to 1 and there be no apparent stenosis at all. So we require visible narrowing as well. At the venous graft anastomosis or intragraft, that's the most common. The venous graft is the most common area of stenosis, and we require a peak systolic velocity ratio of only 2 to 1 or around 2 to 1, but also we need a visible narrowing. The only place in the graft that this doesn't apply that I've been fooled at is near the apex of the graft in a forearm loop graft or perhaps in an upper arm loop graft. Sometimes the most caudal portion of that graft, as it loops around, can do a little kinking. It's questionable. The angiographers don't call that a stenosis, but it is, in effect, a functional stenosis. But you have to make sure that you don't inadvertently send a patient for a stenosis that is just a kinking of the graft that the angiographers aren't going to be able to angioplasty. And then in the feeding artery or in the draining vein, we use a peak systolic velocity ratio of greater than 2 to 1, and again, visible narrowing. So it should be, we should measure blood flow, which is also called volume flow, so that we get some degree, some assessment of the degree of blood flow, whether it's 5 cc's a minute or 500 cc's a minute or a liter a minute. It's going to lead us to a little bit different conclusion, and we'll talk about that in a minute. If there is severe swelling and we haven't found a definite stenosis yet, you need to look for a DVT. Look in the brachial veins and in the axillary veins. And then if it's a lower extremity thigh graft, you need to look at the common femoral vein and external iliac veins if you can. Then you need to look centrally. And those central veins are the internal jugular vein and the subclavian vein, or the common femoral veins bilaterally. And you need to compress those to make sure that there's no stenosis or clot there. And then put color and spectral Doppler on. And what you're looking for is a spectral waveform that's abnormal and monophasic. We're assessing respiratory phasicity and also assessing transmitted cardiac pulsatility. And in the detection of central stenosis, we also can look at the brachiocephalic vein and the SVC. We can't always see the SVC. We can't always see the brachiocephalic vein because they are covered by lung. But, and likewise, the common iliac vein and IVC are covered by bowel. But sometimes you can put a small sector transducer either in the suprasternal notch or above the medial clavicle, or in a thin patient, you can look at the common iliac vein and the IVC, and sometimes you can actually see well these central structures. So you need to basically try. This is a patient that has had a recent angioplasty, had a fistula. Here's that fistula coming in, and all we're seeing is a dilated vein filled with clot. Their angioplasty was obviously unsuccessful, and their subclavian vein is occluded. This is putting color on, and you can see that there's a pulsating artery adjacent to where the subclavian vein should be. And we, of course, verify that with a still image with Doppler on. The little bit of pulsation you see is from arterial pulsation. Now, this is this is the same patient actually, and so left subclavian is thrombosed, right internal jugular vein is monophasic. I call this very tightly. It needs to go all the way back to baseline to normal. And the subclavian vein is also monophasic, and that would infer that there's a central stenosis or occlusion, and since this is a bilateral process, that thrombus from the left may extend all the way to the SVC. This is another patient with very monophasic central venous flow on the right and also in the left. Very, very abnormal. And this is a patient with bilateral brachiocephalic vein occlusion. You can see where this person's left medial subclavian and brachiocephalic vein is, and you can't even see where the right side is as well. Here's the SVC. So this patient's got a significant problem and cannot have a fistula or a graft in the upper extremity. This is an unusual finding. We see it about once a year now, and this is a patient that has reverse flow in the internal jugular vein. It's pretty cool when we see it. Notice that there is good respiratory phasicity, which means that there's some collaterals that are connecting to the central chest. And this is the angiogram of that patient. And here is the occlusion of the brachiocephalic vein, and there is what flow is present in that internal jugular vein is coming up in a retrograde fashion. If you see abnormal waveforms, what you need to do is to get a fistulogram or an MRI for central vein evaluation. For the fistulogram, that could potentially be therapeutic in selected patients because they could perform an angioplasty or they could place a stent. So if there's a strong suspicion, you could do that. If there's a less strong suspicion, you could do an MRI, but that is an issue these days with patients with elevated creatinine. We don't usually give gadolinium because of the possibility of nephrogenic systemic fibrosis. However, there is an alternative. You can perform MRI without contrast using cardiac gating to assess the central veins. You're going to need a newer package probably on your MRI, but often people have that capability. Now, what happens if the ultrasound axis is negative and there's no DVT? What do you do next? Well, this is usually in the setting of high access flow, so you will end up with a patient that maybe has a liter or more going through their fistula or graft. You'll need to do an angiogram because you will often, in those cases, find central stenosis or occlusion. So in those patients with diffuse significant arm swelling, if it's only mild or it's not causing any issues for that patient, you probably shouldn't refer them for an angioplasty. You should wait until the swelling is severe because you may extend that access life. Because there are some papers that demonstrate that if you angioplasty an asymptomatic stenosis, that you may be causing more harm than good, and you may shorten the access life. But successful angioplasty plus or minus stenting will usually resolve the symptoms of edema. So in summary, we have talked extensively about what to do in the swollen extremity with an access. You can triage with the clinical history and examination. You can pretty much figure out what you're going to have to do. Basically, you determine whether there's a focal mass or diffuse swelling. If it's a focal mass, you can do a limited examination and just bill a subcutaneous tissue code. Now, I do put the Doppler on just to assess patency, but I don't charge for that because it's a 1 second on and off. So remember, those can be a much more shortened exam. But if it's diffuse, you will need to do an entire access evaluation. And then if you don't see an etiology for the swelling in terms of access malfunction, then you need to go on and do a DVT study. And if you still don't see any etiology for that swelling, you need to study the central veins. Thank you.